I want you to do something before I say another word. Look at your hands, not a glance. Really look at them. The skin on the back, the texture of your knuckles, the color of your fingertips, the thickness of your nails, the creases across your palms. Most people have not looked at their hands, really looked, in years. They use them every minute of every day and almost never examine them. I want to change that today, because what is written in your hands, if you know how to read it, may be telling you something about your blood sugar that no one has ever taught you to notice. I spent over 2 decades working inside a medical system that is extraordinarily good at diagnosing diabetes after it has already caused damage. After the A1C has been climbing for years, after the complications have begun, after the conversation shifts from prevention to management. What that system is not designed to do, what the 15-minute appointment simply does not have time to address, is teach people to read the early signals their own body has been sending for months or years before any test came back abnormal. Your hands are one of the most revealing surfaces in the human body for early metabolic dysfunction, not because of one dramatic sign, because of a specific set of quiet, gradual changes that most people attribute to aging, to dryness, to working with their hands, to anything except what they may actually represent. Today I am going to walk you through 9 of those signs. 9 specific observable changes in the hands that have documented associations with insulin resistance, elevated blood sugar, and early diabetic neuropathy and vascular compromise. Some of them you will recognize immediately in your own hands. Some will surprise you. And at least one, I will tell you now, is the one that consistently produces the strongest reaction when I explain the mechanism behind it. Because it is something almost everyone over 50 has noticed, and almost no one has ever connected to blood sugar. This is not a diagnostic tool. I want to be clear about that from the beginning. None of these signs confirms diabetes. None of them replaces a blood test. What they are is a practical framework for knowing when to ask a question that your doctor may not have thought to prompt you to ask. Because the single most powerful intervention available for type 2 diabetes and insulin resistance is early detection, years before the complications, years before the conversation narrows. And early detection begins with noticing. Stay with me. Keep your hands where you can see them. Let me start with the biology, because without it, the 9 signs will feel like a list of things to be anxious about. With it, they become a coherent picture of a single process, a process that is reversible in its early stages, in ways that most people are never told. Your hands receive blood supply through 2 primary arterial arches, the superficial and deep palmar arches, fed by the radial and ulnar arteries. The fingers themselves are supplied by digital arteries so small that their inner diameter, in some cases, is less than a millimeter. They are among the most distally located vessels in the entire human body, which means they are among the first to show the consequences of vascular compromise. The nerves that supply the hands follow the median, ulnar, and radial nerve distributions. The peripheral nerve fibers that carry sensory information from the fingertips and palmar skin are among the longest unmyelinated and thinly myelinated fibers in the nervous system. They are among the first to show damage from the metabolic environment that elevated blood sugar creates. And the skin of the hands, particularly the skin over the knuckles, the dorsal surface, and the fingertips, is directly exposed to the consequences of the hormonal and metabolic changes that insulin resistance and elevated blood sugar produce. This is why the hands reveal so much. Not because they are uniquely fragile, because they sit at the end of every system that elevated blood sugar damages first. The vessels, the nerves, the skin, the tendons, all of them concentrated in a small, visible, examinable space that you carry with you everywhere. Now, the 9 signs. The first sign, skin thickening over the knuckles, particularly the knuckle pads on the back of the hand. This is one of the subtlest signs on this list, and it is one of the most consistently overlooked because it happens gradually and looks, from a distance, like nothing more than rough, slightly thickened skin over the joints. What is actually happening is a process called diabetic cheroarthropathy, a term that literally means diabetic hand stiffness. It is caused by the glycation of collagen, the attachment of glucose molecules to collagen fibers in the skin and connective tissue of the hands. Here is what glycation does to collagen specifically. Normal collagen fibers are organized, flexible, and regularly cross-linked through enzymatic processes that maintain structural integrity while preserving elasticity. When excess glucose is present in the tissue environment, non-enzymatic glycation occurs. Glucose attaches to collagen fibers in a chemically disorganized way, creating what are called advanced glycation end products, or AGEs. These glycated collagen fibers become stiffer, more cross-linked, and less responsive to the mechanical demands placed on them. The result in the skin is visible thickening. The dermis, the deeper layer of skin, accumulates glycated collagen that does not turn over normally. The skin over the knuckles becomes slightly thickened, waxy in texture in some people, and less supple than it should be. There is a clinical test associated with this process called the prayer sign, or more precisely, the inability to fully approximate the palmar surfaces of both hands when pressed together, due to skin and tendon stiffness in the fingers. It was first described in people with long-standing type 1 diabetes, but it appears in subtler forms in people with insulin resistance and type 2 diabetes long before formal diagnosis. Look at the knuckles of your dominant hand right now. Run a fingertip across the skin over those joints. Compare the texture to the skin of your inner forearm. If the difference is more than you would expect, if the knuckle skin feels notably thicker, drier, or less supple than it did 5 or 10 years ago in a way that goes beyond normal aging, that observation is worth noting. This sign does not diagnose anything. It is one piece of a picture, but it is a piece that is written in a place most people never think to read. The second sign: slow healing cuts, cracks, or abrasions on the hands, particularly on the fingertips and the skin around the nails. This one, I want to approach from a mechanism-first direction, because the mechanism is the reason the sign is so clinically significant, and why dismissing it as, "my hands are just dry," is a decision that deserves more scrutiny. The healing of any wound in the skin, even a minor crack at the corner of a fingertip, requires 3 things to happen in sequence. First, adequate blood flow to deliver oxygen, immune cells, growth factors, and the building materials for new tissue. Second, functional platelet activity to initiate clot formation and growth factor release. Third, the ability of fibroblasts, the cells responsible for generating new collagen, to proliferate and migrate into the wound site. Elevated blood sugar impairs all 3 of these processes through different mechanisms. Blood flow to the distal extremities is reduced because high glucose damages the endothelium of the small vessels that supply the skin of the hands, the same microvascular changes that eventually produce the complications affecting the eyes and kidneys, beginning in the small vessels of the fingers years before they become clinically apparent in other locations. Platelet function is altered in a hyperglycemic environment. Platelets become more reactive and tend to aggregate in ways that paradoxically impair rather than support the organized healing response. And the glucose-rich tissue environment impairs fibroblast proliferation. The cells responsible for generating new collagen to fill the wound cannot function at full efficiency when surrounded by the metabolic byproducts of chronically elevated blood sugar. The result is a wound healing trajectory that is measurably slower than it should be. Not dramatically slow in early insulin resistance. Dramatically slow is a later stage finding. Subtly slow. A crack in the skin of the fingertip that takes 2 weeks to close instead of 4 or 5 days. A cut that seemed healed and then reopened. An abrasion around a cuticle that stays inflamed far longer than expected. Most people attribute this to winter dryness, to working with their hands, to aging skin that simply heals more slowly. Some of that is true. Skin does heal more slowly with age, but the rate of change matters. If your hands have begun healing noticeably more slowly than they did 5 years ago, in a way that goes beyond seasonal dryness, that observation belongs in a conversation with your doctor alongside a blood sugar measurement. The third sign: tingling, numbness, or a pins and needles sensation in the fingers, particularly the index and middle fingers and the thumb. I want to be specific about the distribution here, because the distribution is clinically informative in a way that most people don't realize. The median nerve, one of the 3 primary nerves supplying the hand, carries sensory information from the thumb, index finger, middle finger, and the radial half of the ring finger. When people describe tingling or numbness in those specific fingers, particularly when it is bilateral, present in both hands, and particularly when it is worse at night or first thing in the morning, it is describing a pattern that is consistent with two distinct processes that can occur together or separately in early metabolic dysfunction. The first is peripheral diabetic neuropathy, the progressive damage to peripheral nerve fibers caused by the metabolic environment of elevated blood sugar and the reduced microvascular supply to the nerves themselves. The small blood vessels that supply peripheral nerve fibers, called vasa nervorum, are among the earliest casualties of diabetic microvascular disease. When these vessels are damaged, the nerve fibers they supply become ischemic. The early symptom of ischemic nerve tissue is abnormal sensation, tingling, burning, a sensation of pressure or tightness. The second process is carpal tunnel syndrome, compression of the median nerve at the wrist, which has a well-documented and significantly elevated prevalence in people with insulin resistance and type 2 diabetes. The mechanism involves the glycation of tendon and ligament tissue in the carpal tunnel, which reduces the space available for the median nerve and increases the pressure on it. Both processes share the same root cause: the metabolic environment that elevated blood sugar creates in the tissues of the hand. Tingling in the fingers is an extremely common complaint, and most cases have benign explanations: sleeping position, repetitive use, temporary compression. But tingling that is bilateral, that involves the specific median nerve distribution, and that occurs without an obvious mechanical explanation, deserves evaluation, including a fasting blood sugar test. If you have been noticing tingling or numbness in your hands, particularly in those first three fingers, particularly at night or in the morning, put that observation in the conversation with your doctor, explicitly, because the connection between that symptom and blood sugar is one that the appointment doesn't always make time to draw. And if this is the kind of conversation you want more of, the mechanism behind the symptom, not just the symptom itself, I want to ask you now to subscribe to this channel. Turn on notifications. This is exactly what we do here every week. Direct, specific, mechanistic medical information that the system doesn't make time to explain. Hit subscribe. Keep your hands where you can see them. Let's continue. The fourth sign: burning sensation in the fingers or palms, particularly in the absence of any external heat source, and particularly at night. This sign is the one that most people dismiss most quickly, because burning without a cause is easy to explain away as stress, as poor circulation from sitting in the same position, as something that will resolve on its own. I want to explain why dismissing it quickly can be a significant mistake, and why the mechanism behind it is one of the most important things to understand about early diabetic neuropathy in the hands. Peripheral nerve fibers carry two categories of sensory information: normal signals that accurately report the state of the tissue, temperature, pressure, pain, and pathological signals that the damaged fiber generates spontaneously without any external stimulus. In the early stages of diabetic peripheral neuropathy, nerve fibers do not simply fail to transmit signals. They become hyperexcitable. The metabolic damage to the fiber, the combination of ischemia from microvascular disease and direct glucose-mediated injury to the nerve cell membrane, alters the electrical properties of the fiber in a way that causes it to generate spontaneous action potentials. Signals that travel up to the brain and are interpreted as sensation in the absence of any actual stimulus. Burning that no external source is producing. Heat that is not there. This is the neural equivalent of a fire alarm that goes off in an empty building. Not because there is no fire, but because the alarm's sensing mechanism has been damaged. The burning pattern associated with early diabetic neuropathy in the hands typically follows nerve distributions. It is not random. It may be confined to the fingertips. It may involve the palmar surface of the hand in the median nerve distribution. It tends to be worse when the hands are at rest and better with movement because activity increases blood flow to the nerve tissue temporarily. If you are experiencing burning in your hands, particularly at night, particularly in your fingers or palm, rather than diffusely across the whole hand, that symptom, combined with even one or two of the other signs on this list, represents a pattern worth evaluating with a blood sugar measurement. The fifth sign: skin color changes on the back of the hand, specifically a darkening or bronzing of the skin over the knuckles, or a pattern of darker pigmentation in the skin creases of the palm. This is the sign I mentioned at the beginning, the one that produces the strongest reaction. And I want to explain exactly why. There is a condition called acanthosis nigricans. It is a dermatological manifestation of insulin resistance, not of diabetes itself, but specifically of the insulin resistance that precedes and underlies type 2 diabetes in the vast majority of cases. The mechanism involves elevated insulin levels in the bloodstream. When cells become resistant to insulin, the pancreas compensates by producing more of it. Blood insulin levels rise, a state called hyperinsulinemia, and high levels of insulin in the circulation bind to receptors on skin cells called insulin-like growth factor receptors. This binding stimulates keratinocyte proliferation, the overproduction of skin cells, and increases the production of dermal melanin. The result is a darkening of the skin in characteristic locations: the back of the neck, the armpits, the groin, and the knuckles, the skin over the finger joints, and sometimes the skin creases of the palm. The darkening is not from sun exposure. It does not come off with washing. It is a pigmentary change driven by a hormonal signal, elevated insulin. That is itself a consequence of the same metabolic dysfunction that will eventually produce type 2 diabetes if it is not addressed. This sign is particularly significant because it appears in the insulin-resistant phase, before blood sugar is markedly elevated, before an A1C test is flagged as abnormal. It is a window into the metabolic environment before the window has closed. Look at the skin over your knuckles right now. Compare it to the skin on the back of your hand between the joints. Is there a noticeable difference in pigmentation? Darker, thicker-looking skin specifically over the knuckle joints? This is one of the most direct, visible, immediately observable signs of insulin resistance that exists. And most people who have it have never been told what it means. They have been told it is hyperpigmentation. They have been told it is from sun damage. They have been told it is something to discuss with a dermatologist. It is something to discuss with a doctor alongside a fasting insulin and fasting glucose test. The sixth sign: dry, thickened skin on the palms, particularly skin that cracks at the fingertips or along the lines of the fingers regardless of moisturizer use. I want to distinguish this from ordinary winter dryness, because the distinction matters clinically and because most people conflate the two. Ordinary skin dryness responds to moisturizer. It improves with humidity. It resolves when the season changes. It does not crack repeatedly in the same locations regardless of how carefully the skin is treated. The dryness associated with metabolic dysfunction in the hands follows a different pattern. It is persistent. It tends to localize at the fingertips, particularly the tips of the index and middle fingers, and at the borders of the palm. Moisturizer provides temporary relief, but the skin returns to its dry, thickened state within hours. The cracks that form may be painful, slow to close, and recurrent in exactly the same locations. The mechanism involves two processes operating simultaneously. The first is damage to the autonomic nerve fibers that regulate the eccrine sweat glands in the skin of the hands. These glands are responsible for maintaining the surface hydration of palmar and finger skin, not through visible sweating, but through continuous low-level moisture regulation. When the small autonomic nerve fibers supplying these glands are damaged by the metabolic environment of elevated blood sugar, the glands reduce their output. The skin surface becomes consistently drier than normal from the inside out, not from inadequate moisturizing from the outside. The second process is the accumulation of glycated collagen in the dermis that we discussed in the first sign, which reduces the skin's natural ability to retain water within its structure. Skin that is dry from the inside out, driven by autonomic nerve damage and structural collagen changes, does not respond fully to external moisturizing. This is why the pattern is clinically useful. Persistent, treatment-resistant dryness in the hands of someone over 50, particularly at the fingertips and palm borders, in the absence of an obvious occupational or environmental explanation, is a pattern worth examining in the context of metabolic health. The seventh sign: thickening or yellowing of the fingernails, particularly changes in nail texture that are not attributable to a fungal infection. I want to address the fungal explanation first, because it is the most common alternative explanation, and because the distinction between fungal nail changes and metabolic nail changes is one that most people, and honestly, many primary care providers, do not examine carefully. Fungal nail infection, onychomycosis, produces characteristic changes: Thickening of the nail plate. Whitish or yellowish discoloration that typically begins at the free edge and progresses toward the base. Separation of the nail from the nail bed. And in some cases, a crumbling texture. It tends to affect one or a few nails initially and progresses at variable rates. The nail changes associated with elevated blood sugar and impaired circulation in the hands produce a somewhat different picture. The nails may thicken, but the thickening tends to be more uniform across all nails rather than patchy. The color change, a yellowing or an unusual opacity to the nail plate, may occur without the separation and crumbling of fungal infection. The growth rate of the nails may slow noticeably. The mechanism involves reduced blood supply to the nail matrix, the germinal tissue at the base of the nail that produces the nail plate. Microvascular compromise in the small vessels supplying the nail matrix reduces the metabolic support available to the nail-producing cells. The nail grows more slowly. Its structure becomes less well organized. The plate may thicken as cell turnover in the matrix slows and the cells that are produced are less precisely organized. The practical implication is this. If your nails have changed in texture, growth rate, or color in ways that don't fully match the pattern of fungal infection, and particularly if this is occurring alongside other signs on this list, metabolic evaluation is warranted alongside or instead of antifungal treatment. Nail changes that are treated repeatedly for fungus and never fully resolved deserve a different diagnostic question. The eighth sign, reduced grip strength or stiffness in the fingers, particularly first thing in the morning, that goes beyond what you would attribute to arthritis or age. This is the sign that requires the most nuance, because stiffness in the hands with aging is genuinely common and genuinely has multiple causes. I am not suggesting that morning stiffness means diabetes. I am suggesting that a specific pattern of stiffness, in combination with other signs on this list, deserves attention. The mechanism, in the context of elevated blood sugar, involves the glycation of the tendons, tendon sheaths, and joint capsule structures of the finger joints. The same collagen glycation we discussed in the first sign, the accumulation of advanced glycation end products in collagen, affects not just the skin but the deeper connective tissue structures that give the fingers their flexibility. Glycated tendons become stiffer. They slide less freely in their sheaths. The resistance to movement that results manifests as a sensation of stiffness that is most pronounced when the tissues have been immobile during sleep, and that gradually reduces with movement as blood flow and tissue temperature increase. The specific clinical entity associated with diabetic hand involvement is called diabetic cheiroarthropathy, the same term we touched on in the first sign. It involves stiffness that progresses from the little finger toward the thumb, limited joint mobility on examination, and in some cases, a flexion contracture, the finger that cannot fully straighten, called Dupuytren's-like contracture, which has elevated prevalence in people with diabetes and insulin resistance. The morning stiffness associated with inflammatory arthritis, rheumatoid arthritis, tends to be more symmetrical, involves more joints, and is associated with warmth and swelling. The stiffness associated with metabolic connective tissue changes tends to be most prominent in the small joints of the fingers, develops gradually, and is not typically associated with the inflammation and warmth of autoimmune joint disease. If your morning hand stiffness has been increasing, if it involves your fingers specifically rather than your wrists or larger joints, and if it occurs alongside even a few of the other signs on this list, it belongs in a conversation about blood sugar alongside a conversation about joint health. The ninth sign. This is the one I want you to pay the most careful attention to. Not because it is the most dramatic. It is actually one of the most subtle on this list, but because it is the one that most consistently signals something specific about the vascular supply to the hands, and because it is something that most people over 50 have noticed and never connected to anything metabolic. Loss of the fine hair on the back of the hands and fingers. Look at the back of your hands right now. Look at the skin over the knuckles and along the fingers, particularly the proximal and middle segments. Is there hair there? In most adults, there should be fine, light hair that covers the dorsal surface of the fingers and the back of the hand. In people with progressive microvascular compromise from insulin resistance and elevated blood sugar, the blood supply to the hair follicles in this area is gradually reduced. The follicles, which require a continuous, adequate blood supply to maintain the hair growth cycle, receive insufficient oxygen and nutrients. the hair growth cycle slows. Hairs in the telogen phase are not replaced in the anagen phase. Over time, the density of fine hair on the dorsal surface of the hand and fingers decreases. This is the same mechanism that produces hair loss on the lower legs and feet in people with more advanced peripheral arterial disease. A loss of hair over the extremities that reflects inadequate blood supply to the follicles at the distal extremities. In the hands, this sign appears at an earlier stage, because the fine hair follicles on the dorsal surface of the fingers are more metabolically sensitive than the heavier hair follicles of the lower limb. Most people who notice this, and not everyone does, because the hair is fine and the loss is gradual, attribute it to aging. Some aging-related reduction in fine body hair is normal, but a noticeable difference in hair density between the dorsal surface of your hands now and what you remember from 10 or 15 years ago, particularly occurring alongside even a few of the signs described today, is a vascular signal worth taking seriously. Now let me bring all 9 signs together, because 9 observations described individually can create a sense of complexity that I want to resolve into something genuinely practical. The 9 signs I have described today are not 9 separate problems. They are 9 windows into the same underlying reality: the progressive metabolic, vascular, and neuropathic consequences of insulin resistance and elevated blood sugar, visible in the hands years before most people receive a formal diagnosis. Skin thickening over the knuckles, collagen glycation, slow wound healing, microvascular compromise and impaired fibroblast function, tingling in the fingers, early peripheral neuropathy and median nerve compression from glycated connective tissue, burning in the fingers, spontaneous neural firing from ischemic and metabolically damaged nerve fibers, knuckle darkening, acanthosis nigricans from hyperinsulinemia, persistent dry skin at the fingertips, autonomic nerve damage to eccrine sweat glands, nail thickening and discoloration, reduced blood supply to the nail matrix, morning finger stiffness, glycation of tendons and joint capsule structures, loss of fine dorsal hair, follicle ischemia from microvascular compromise. Every one of these signs traces back to the same 2 processes: the metabolic environment of elevated insulin and blood sugar acting on the tissues of the hand, and the progressive microvascular and neuropathic damage that environment produces over time. The practical question is not whether you have any of these signs. Most people over 50 will have some. The question is whether you have a pattern, 2, 3, or more of these signs occurring together, particularly if they are new or worsening over the past several years. A pattern is what converts a list of observations into clinical information worth acting on, and the action is simple, not alarming. Simple: a fasting blood glucose test, an HbA1c, a fasting insulin level if your doctor is willing to order it, which gives you the most complete picture of where you are in the insulin resistance spectrum before glucose becomes markedly elevated. These tests take minutes. They are available at any routine blood work appointment. And the information they provide, combined with what you have observed today in your own hands, gives you and your doctor the earliest possible basis for an intervention. Because this is the part I want to say as clearly as I know how. Insulin resistance in its early stages is reversible. Type 2 diabetes, caught before the complications have accumulated, is manageable in ways that type 2 diabetes caught a decade later is not. The difference between acting on a pattern of early signs and waiting for a dramatic symptom or an abnormal test result is measured in years of preserved vascular, neurological, and kidney function. Your hands have been trying to tell you something. Now you know how to listen. Before I close, I want to ask you directly, and I want you to answer in the comments below. Which of these 9 signs did you recognize in your own hands today? Not which one worried you most. Which one you actually saw. Leave it below. Because in my experience, when someone reads a comment that names the exact thing they noticed in their own hands while watching this video, something that was invisible becomes visible, and visible signs can be acted on. And one final thing, if you are not yet subscribed to this channel, do it now, before you look away from this screen and this information fades back into the background of a busy day. Because next week there will be another conversation exactly like this one, and the one after, and the one after that. This channel exists for one reason only: to give you the specific, mechanistic, honest medical information that the appointment doesn't always make time for. Every single week. subscribe, turn on notifications, and share this with one person in your life over 50 who has never once looked at their hands as a metabolic map. That share takes 15 seconds. It could change something that cannot be changed later. The doctor may give the recommendation, but the answer has been in your hands this whole time. Take care of yourselves, stay curious, and keep asking the hard questions, every single one of them.